You probably remember the exact moment you first experienced symptoms of multiple sclerosis, that haziness in your right eye, the tingling of your left arm. But you had MS before, years or decades before. In this video, I'll show you the unequivocal, incontrovertible, unassailable evidence that MS starts years before symptom onset. Citations below. We have strong data that the risk of someone getting MS is likely determined very early in life. For instance, this is a migration study published in 1978 looking at people who migrated to Israel. And they looked at people who migrated from higher prevalence areas like European countries versus lower MS prevalence areas like African and Asian countries. And they looked at when they migrated to Israel. So in the top left is people who migrated early, age 0 to 4 years, and you can see where they came from didn't matter. The prevalence of MS was roughly the same. However, people who migrated later, for instance, age 5 to 14 or greater than 15 years of age, the risk in people coming from European countries, the solid lines, is much, much higher than the risk in people coming from African or Asian countries. It's as though these people retained the risk from their home countries. And other studies suggest the cutoff may be around age 15, where if you migrate to a country early on, you sort of acquire the new risk of MS in the new country, whereas if you migrate later than age 15, you sort of retain the risk of MS from your home country. The virus Epstein-Barr virus, the virus which causes mononucleosis or glandular fever, is definitely linked to MS, but it's acquired early. You can see the seroprevalence, antibodies in the blood against the virus, go up to greater than 80% by age 6 in most countries. So people encounter EBV early in life, and this is a risk factor for MS. We know that living further from the equator and having low sunlight exposure is a risk factor for MS. This study in New Zealand created linear regression lines correlating how sunny where you live is versus the prevalence of MS. And they standardized based on age because obviously if you're 20 years old, you have a lower risk of MS just because you may not have gotten diagnosed yet. And you can see if you look at the location where you lived at birth versus the location you live now, and the study was done in 2006, there's actually a sharper correlation between sunniness and risk of MS in where you lived at birth, suggesting that it's more important, the ultraviolet radiation exposure early in life. Later on, it doesn't make as much of a difference. There's increasing evidence that MS can have a prodromal stage. In other words, there could be subtle symptoms prior to the frank presentation with something like optic neuritis or transverse myelitis. This is a Canadian study that looked at 2,038 people with MS and compared them to about 10,000 people without MS and looked back and saw were there differences in medical encounters prior to reported symptom onset. And they found differences up to 14 years prior to symptom onset when looking at neurological symptoms, and these could be symptoms such as headaches or tingling, some of which may have retrospectively actually been related to MS. They just weren't recognized as symptoms of MS at that time. You can see where 1 means an equal ratio between people without MS and people who subsequently got diagnosed with MS having this medical encounter. There were more nervous system symptoms way back 14 years prior to symptom onset. This is musculoskeletal system, things like achy joints, tendon injuries. You may say, what does that have to do with MS? Why would a sprained ankle have anything to do with subsequent diagnosis of MS years later? Well, in some cases, this kind of pain or discomfort may have actually been a subtle symptom of MS, and you can see the difference is small, perhaps 20 to 30% increase versus people who did not go on to develop MS, but the trend is clear. And lastly, mental health changes. You can see a very clear and statistically significant increase 14 years prior to symptom onset. And it's actually recognized that depression and anxiety can be symptoms of MS, not just a reaction to the stress of having a chronic medical condition, but the actual injury to the brain could be causing mental health challenges. And you can see we're looking at very real 20 to 70% increases in mental health complaints and medical visits years prior to symptom onset. There's some interesting data on neurofilament light chain. Now, this is a breakdown product of the central nervous system that's increased in MS compared to the general population, and higher levels are correlated with a worse prognosis of MS and increased rate of relapses. This study looked 6 years prior to symptom onset of MS and compared people who eventually went on to get diagnosed with MS to the general population. And you can see, on average, they had higher levels of neurofilament light chain in the blood compared to controls. Now, you may say this is a useless test. Many people without MS have higher levels than people with MS, but as a group, the fact that there's a statistically significant difference, p-value of 0.04, suggests that there seem to be higher levels of central nervous system injury in people who later went on to have symptoms of MS, suggesting the disease was likely already starting, at least in some of these individuals. And here's data on neurofilament light chain in the famous US military study that showed that MS was extremely rare in people who did not have antibodies against Epstein-Barr virus. If you look on the left, these are people who ultimately were diagnosed with MS prior to infection with Epstein-Barr virus. They did not have increases in neurofilament light chain compared to the general population. However, after Epstein-Barr virus infection, as adjudicated by blood tests showing antibodies against the virus, but before symptom onset, they did have a very significant increase in neurofilament light chain, at least on average, compared to the general population, suggesting again that there's central nervous system injury occurring prior to symptom onset. Here's a different US military study that looked at proteomics, which proteins are actually expressed in the cell. So you have DNA, but which genes are actually transcribed into messenger RNA and then translated into proteins and have a function in the cell. And they had samples from people who went on to develop MS and compared them to controls. Again, this is years prior to symptom onset, but they were able to detect differences in proteins that were related to complement, which are little particles involved in attacking bacteria, and in lipid transport. So there seemed to be changes occurring in protein expression prior to symptom onset in MS. In some cases, MS can be surprisingly mild, even though pathophysiologic injury is occurring. This is a study on people who had an autopsy and had an unexpected diagnosis of MS after death. In other words, they died for other reasons, but on autopsy, their brains showed demyelinating lesions suggestive of multiple sclerosis. Here's a case series of 18 people where this phenomenon occurred, and 13 out of 18, there was no history of symptoms whatsoever that would be suggestive of MS. In other words, these people essentially lived their entire life having some demyelinating injury to the central nervous system, but did not actually develop symptoms of MS. This could potentially happen with the spine as well. This is a case report of an autopsy from 1974 of a 66-year-old man who died of lung cancer, but the autopsy unexpectedly found a demyelinating plaque in the mid-cervical spinal cord in this region. He did have a history of transient neurological symptoms 30 years prior to his death, but recovered and had no ongoing symptoms. So he had transverse myelitis, not multiple sclerosis, but it was noted the axons, the nerve fibers, were preserved even though there was a demyelinating injury. So sometimes demyelination can be mild and can spontaneously recover, and we see asymptomatic spinal cord lesions in MS from time to time. Next up is the phenomenon of radiologically isolated syndrome, or RIS. This is when someone has an MRI for another reason. Maybe they have a head injury or they have migraine headaches, and they're found to have lesions typical of MS, even though they don't have clear symptoms related to those lesions. And this is happening more and more because we're doing more and more MRI scans in the general population for various reasons. Some of those people go on to develop clinical multiple sclerosis, but some do not. Now, the diagnostic criteria have recently changed such that it is actually possible to have a diagnosis of MS with no clinical symptoms, but all of these publications were published long before that change in diagnostic criteria, so we'll ignore that for a moment. This is a study from Chile which looked at 28 people with RIS. Again, MRI scan looks like multiple sclerosis, but they never had symptoms. They had a median follow-up of 6 years, or 72 months, and 7 of them, 28%, later were diagnosed with clinical multiple sclerosis. The median time to diagnosis was 21 months, but for some people it was much, much longer. For one person who was later diagnosed with primary progressive multiple sclerosis, it was 104 months, or about 8.5 years later. So the clinical pathologic onset of MS, as adjudicated by MRI findings, undoubtedly there's demyelinating injury happening in the brain, if we can see it on MRI scans, occurred over 8 years prior to symptom onset. Here's another similar study on RIS from Boston of the United States. They had 89 participants with a median follow-up of 3.8 years, and 16 or 18% went on to develop clinical multiple sclerosis during this time period. Some of the longer studies suggest the rate may actually be closer to 50%. There are some known predictors, such as having spinal cord lesions, having abnormal cerebral spinal fluid on a spinal tap, or being younger at the time of RIS diagnosis. The median time to the first attack was 3.4 years, and for many people it was much longer. Also, when they got diagnosed with RIS was an arbitrary time period, perhaps when they had something else happen to them like a head injury. In reality, they may have had those demyelinating lesions much earlier, they just didn't have an MRI at that time. So in reality, the time from lesion onset to symptom onset in many of these people is much greater than 3.4 years. And as I mentioned, many of these people will have an abnormal spinal tap if tested. This is a meta-analysis of different RIS studies. Obviously, not everyone with RIS has a spinal tap, but of the 408 people who did have a spinal tap, 293, or 71.8%, had the finding that's typical of multiple sclerosis. In other words, when they had a spinal tap and the cerebrospinal fluid was sent to the lab and a gel electrophoresis was performed and compared to a blood sample at the same time, there were 2 or more bands which represent pathologic antibodies that were not present in the blood. In other words, there's evidence of central nervous system inflammation even in these people who did not have symptoms, some of whom won't even go on to develop clinical multiple sclerosis, though many will. Here's a study that looks at brain volume in people with RIS and compares them to healthy controls and people with relapsing multiple sclerosis. Now, for all of us, our brain is shrinking after age 20 just based on normal aging by about 0.2% per year on average. But in multiple sclerosis, the rate of atrophy can be increased somewhat. And this study found that people with RIS actually have lower brain volume compared to healthy controls. And in fact, it wasn't different in a statistical sense from people who had relapsing remitting multiple sclerosis. So you can say these people with RIS, they have MS. Their brain is shrinking compared to controls. It's just their MS is not that clinically severe at the current time. In the same study, they did neurocognitive testing, and many people with RIS had cognitive impairment. These are some different cognitive tests, and 27.6% of people with RIS had cognitive impairment, which they defined as a low performance on at least 2 of these tests. Now, that was a little bit less than people who had relapsing MS, 34.6%, but not a huge difference. To give an example, the PACE-SAT, or Paced Auditory Serial Addition test, is a test where you hear a series of numbers, for instance 2 and then 4, and then you have to add them together and say the number verbally. So you would say 6, and then you would hear the next number, for instance 3, and you would have to ignore the 6 that you said and add the 3 to the 4 and say 7. And for the PACE-SAT 2, The numbers are coming every 2 seconds. It's an extremely difficult test. And here, people who had multiple sclerosis did do a little bit worse than people who had radiologically isolated syndrome. But for the PACE-3, where the numbers are coming every 3 seconds, there was no statistically significant difference. There's a trend towards lower score in people who actually had clinical multiple sclerosis. So again, you could say RIS is multiple sclerosis. It's just not as severe. The brain is shrinking. Cognitive function is decreasing, at least on average, with great variation from individual to individual. But on average, there's evidence of brain impairment. Here's a case report that I think is instructive. This is a 15-year-old girl who had an MRI scan for fever and drowsiness. That illness improved and was subsequently thought to be some kind of viral illness that had nothing to do with multiple sclerosis. However, she had an MRI scan that revealed demyelinating plaques, and you can see the lesions are in fact typical of MS. She was followed for a total of 18 years, and she never had a clinical relapse. She never had transverse myelitis. She never complained of vertigo or double vision. She never had numbness or weakness. However, she had new MRI lesions on some of the subsequent follow-up MRI scans. After 18 years, she was doing well. Her EDSS score, this is a measure of disability, a 0 to 10 scale, was only 1.5, a very low level of disability. She had brisk reflexes and some difficulty with tandem gait. This is walking with one foot placed directly in front of the prior foot, a test of balance function. Now, in my opinion, their diagnosis is wrong. A 33-year-old should be able to perform tandem gait very easily unless there's some other kind of injury, so she really just has multiple sclerosis, in my opinion. However, the point is it possible to have clear radiologic evidence of injury to the central nervous system with no actual complaint of significant neurological symptoms? The answer is definitely yes. So to put it all together, I think there's very strong evidence that typically MS starts long before actual reported symptom onset. Now, occasionally I'll have a patient, for instance, that might have something like double vision. They have an MRI scan of the brain. There's a single demyelinating lesion in the pons that explains the double vision, no other lesions in the central nervous system. And then later on, they develop more lesions and more attacks typical of MS. They had no prodromal symptoms. Maybe in that patient, I am coincidentally seeing them right at the time of clinical pathologic onset of the disease, because coincidentally they had inflammation in a critical area that caused obvious symptoms leading to diagnosis. However, for the typical person, when they have a demyelinating event, we do an MRI scan and we see many, many lesions which look old. Of course, there's no way to determine exactly how old they are, but I think this overall evidence suggests they've likely been there for a long time. I think a lot of people think of MS as something like Guillain-Barré syndrome. You get a viral infection, and then a few weeks later you develop tingling, and it spreads up your body, and you develop weakness, and you have inflammatory injury to the peripheral nervous system. But that's different. That person really didn't have any neurological disease prior to getting the flu. What's happening there is the virus actually causes molecular mimicry, where coincidentally the antigens on that virus are recognized by your lymphocytes. They look similar to components of myelin, and it induces this cross reaction. That's very different from multiple sclerosis, where there are chronic changes likely occurring over years with dysregulation of the immune system, perhaps some changes in the blood-brain barrier, and maybe other changes we don't fully understand that lead to the pathogenesis of MS over years. It's not simply a one-time thing. And what is the significance of this? Well, one is I think a lot of people really focus on those days or weeks right before symptom onset, and they really stress about it and say, did I somehow cause my multiple sclerosis? And I would say don't worry about it. It's highly likely that the pathophysiologic onset of MS occurred years before. The other thing is, if we want to prevent people from getting multiple sclerosis, we can't really focus too much on the time right before symptom onset. We have to look at early childhood and adolescence and see what we can intervene on then, like sunlight exposure, maybe vaccination against Epstein-Barr virus, maybe diet or hygiene during early childhood, that kind of thing. That would likely have a much greater impact than anything we're going to do in someone's 20s or 30s. Let me know what you think about this topic. Did you think MS could be triggered by something that happened in your life? And was it something that was shortly before symptom onset or years before? Or do you just not know? And let me know if you have any suggestions for other videos.